you forget sometimes. It's all about exposure. So I don't know if we ever talked about this or if I ever told you the story, but when I was at Hopkins, there was a shooting in the hospital. So there was a murder. So a woman, older woman, went through surgery, some sort of like spinal stenosis surgery, like fairly routine surgery, but something happened, which happens, and she ended up paralyzed, some terrible complication. So the son came to the hospital with a gun, went up to the floor, fortunately didn't kill anyone, I don't think, but tried to assassinate the doctor, tried to murder the doctor who had operated, was taken down by the police, and I was in charge of the unit in the day hospital at the time. And it's like, how? So we had all these meetings. How do we explain this? This is terrible. Parents and kids come to the hospital to be in a safe environment. We've betrayed their trust. This is an institutional disaster.
Oh.
And we talked to the kids. Kids were fine.
Oh.
They were like, it was in another part of the hospital. We're fine. Because this is their everyday life when there are shootings up the street. And they were completely unfazed by it. So it's just taking into account the environment and all of those stressors and sort of context. It's so important. And we were way more shaken by it than they were.
Wow.
It didn't
Yeah.
affect them at all.
Yeah. They live with gunshots in the background.
Yep.
Yeah. That's incredible. Very sad, but also, I guess, they're habituated and it's just another day. It's a different
Right.
kind of, it's almost like dissociating.
It's
Yeah.
so fascinating. And it's one of the things that we're going to talk about, but the relationship between the traumatic exposure and the response to the trauma and how you come out the other side. It was really interesting
Mm.
just to see how all these relationships between the exposure and the response really play out.
Wow. Yeah.
Welcome to the Good.Enough.Shrink podcast. We are your hosts. I am Jenna Chang, a child, adolescent, and adult psychiatrist practicing here in Los Angeles, California.
And I'm Dr. Patrick Kelly. I am also a child, adolescent, and adult psychiatrist practicing in the Los Angeles area.
We are on a mission to demystify child psychiatry and have conversations surrounding difficult topics on youth and adult mental health, but not without a little play along the way. Welcome back to the podcast. So we are starting a multi-part series on trauma, which is a big topic. So we wanted to break it down to multiple episodes to make sure that we highlight what we feel is important in our field in regards to trauma. So today we're focused on PTSD and its history, its definitions, and also stigma, as well as the role of memory in it. So we hope you enjoy it. We hope you find new perspectives in it. And here we go.
And in our last episode that we spoke about together, we talked about addiction. We talked about some of the precursors to addiction and substance use and how a lot of the risk factors have to do with negative life experiences, and some of those can be trauma and traumatic experiences. So we wanted to talk more about what most people think of when they think of trauma, PTSD, post-traumatic stress disorder, what that is, how that fits in, because I think it's something that has entered almost the casual conversation or the zeitgeist. People sort of say, that test was so bad it gave me PTSD. Or that movie was so terrible, I have PTSD because of it. So I think there's sort of a casual use about it. So I think it's always good that people are talking more about mental health. Don't get me wrong, but I also think that can lead to a misunderstanding of what it really is, how we define it, and most importantly, I think what we do about it when we recognize it. So I have to admit that in looking into this topic, it's one of those topics that could be, an entire podcast in itself. It's huge, and there's so much research about it, and there's so much knowledge that's emerging about it. So I would consider this an overview, an intro. And even then, we're probably going to spend a few episodes talking about this, but the ideas that we bring forward, all of them can go much, much, much deeper. But as we usually do, I think it's always important to start with where this came from and how we as a field started to think about it. PTSD, it stands for post-traumatic stress disorder. So the definition is in the name. So you have to have a trauma exposure, and we'll talk about what that is. And it is a stress disorder. So it is a mental health disorder that emerges from your response to the trauma that you experienced. So the word trauma is actually from a Greek word. I can't pronounce it. I'm not even going to try, but it means wound. So it's the idea that there's a psychological injury, a psychological wound that most of the time comes from something that has happened in your life. The definition of what is a trauma and what is not a trauma is pretty complicated and nuanced, and we'll talk about that. But when we started to recognize that it can emerge into a psychiatric condition, because believe it or not, there are not that many psychiatric diagnoses that are the direct result of a life experience. Most of them we think of as either emerging from your development or your biology, something like autism or depression, or emerging from a complicated sequence of behaviors that becomes self-repeating, like addiction, like we were talking about before. But this is the idea that something happens, and because of your response to it, you now have this psychiatric diagnosis. So it was first officially recognized or codified in the DSM in the 1980s, but we do have evidence that it was recognized as a phenomenon much earlier. So the earliest information I could find about this was there was a paper that discussed reports of soldiers in the Mesopotamian Empire 3,000 years ago who talked about flashbacks, sleep problems, seeing ghosts of the soldiers, the other people that they had killed, the traumatic response to war, which is probably the biggest example that we have nowadays of PTSD. Most people, when they think of PTSD and where it occurs, lots of people do think about war and soldiers and sort of wartime and military. So it makes sense that that's one of the first places that we as a civilization might have recognized it. But even very recently, in World War I, World War II, the Vietnam War, the Korean War, people talked about shellshock. And it wasn't called PTSD. It wasn't recognized really as a condition, but there was some recognition that some people, and frankly, there was a lot of stigma and blame about it, some people who couldn't handle it had a more extreme response and could never get back on their feet after being in war. We now know that it's not the fault of the person. It's like saying if you trip and fall and you break your arm, or if you trip and fall and if you don't break your arm, it's your fault for whether you broke your arm or not. It's not that person's fault, but there is still a lot of stigma around the idea of PTSD, that there's something about you that you're less tolerant of these exposures.
Yeah, with shell shock, they thought that it was that the soldiers were not disciplined enough or they were not trained well enough. And so the solution to shell shock was to hunker down on training and be more strict. And I think also they were seeing these angry outbursts and flashbacks, intrusive symptoms, but then couldn't tell the difference between that, a traumatic response, and something else where they used to call it neurosis, but so they had this term called neurasthenia that I was reading about, where it was basically the weakness of the nerves or the exhaustion of the nerves, and it would include fatigue, anxiety, and sleep problems. And so it was up to the treating psychiatrist or physician to determine, is this shell shock or neurasthenia? And if it's neurasthenia, you don't do anything about it. You just let them sulk and be miserable. And if it's shell shock, you put a lot of discipline on that. And so it's like you really can't get any relief either way. So yeah, I think our understanding was very, very lacking, to say the least.
Yeah, absolutely. We've definitely come a long way. And, who knows? Maybe people in 100 years will look back and think, listening to this podcast, what were they talking about? They had no idea. What a horribly misunderstood conceptualization of PTSD, but we're where we are and we're trying to continue to evolve with the best knowledge that we had. But absolutely true that I think a lot of the stigma comes from what people were told growing up. It was kind of an institutional stigma against PTSD and trauma and reactions based on a lot of misunderstanding. So, and actually, it's only in the newest edition of the DSM, the DSM-5, that trauma and related disorders are their own category. They used to be under anxiety disorders. So now they're separated out because of that exposure relationship. So there are a few conditions in the trauma and related disorder category. So there's acute stress disorder and post-traumatic stress disorder. The symptoms of those are very similar. The timeline is different. And the reason for that is that most people who have a traumatic exposure, and even most people who go on to develop an acute stress disorder, self-resolve, do not go on to have post-traumatic stress disorder. So the idea that your response to the trauma changes based on the time from when the trauma occurred is very important because a lot of the treatments for PTSD can be pretty intense, but for acute stress disorder, most of the time are frankly unnecessary. And a lot of those resolve on their own. So you want the treatment to match the condition. And so this dividing line of time actually turned out to be so important that there are two separate diagnoses. There's also an adjustment disorder, which is less dependent on a big T, capital T trauma exposure. It's more that there is some sort of change, some sort of exposure. And as a result of that, you have psychological symptoms or psychiatric symptoms. And there's also prolonged grief disorder, which is very specific to almost always the death of a loved one. And it has specific symptoms related to that. But they all hang together based off of that idea of exposure with resulting condition.
Yeah. And the timeline of this always tripped me up a little bit because, for example, adjustment disorder, it's from the time that whatever stressor ends and the symptoms will resolve within 6 months. And it's really hard to specifically point out when it ended. And so I think sometimes these timelines can be a little bit arbitrary because in general, you're looking at, okay, within 6 months, are the symptoms getting better? Is it resolving? Is it generally looking like they are going back to work or school? So I think it gets a little hazy there. But I think what it does, I'm trying to look at the process of DSM, using the DSM, which is that it makes me really listen because I'm really listening to transitions. And so I think the point of this clinically, I understand research, you have to have specific measures, but clinically, I think it just forces you to listen in on details.
I think that's so true. And that's a big part of our field, I think, is to really pay attention to those critical details as the patient is talking. It's certainly not the same as going through a checklist like you would have to do for research, but it also turns out to be important. It's much more than a casual conversation of just investigating because you're right. Even the timeline, it can seem like sometimes we get hung up on it when we're talking to patients and we're being nitpicky, but it can be really important. And evidence bears that out, that the difference of a week can actually make a huge difference in someone's recovery path.
Mm-hmm. Yeah. So, PTSD is a condition that is triggered by experiencing or witnessing a traumatic event. You really don't have to be exposed to that specific event. If it happens to someone you love or someone very, very close to you, you can also get PTSD from that. So, as a requirement, it's necessary to have both the exposure to trauma, including witnessing and experiencing, and a prolonged or delayed disabling response. The disabling response can be intrusive symptoms, negative affect, negative cognition, and avoidance. But the symptoms of PTSD alone without exposure are themselves evidence that someone must have experienced some sort of trauma in the past, whether or not they can recall the event.
That's so important. My former chair at Hopkins, where I trained, made her whole career out of this, out of the idea of suppressed memories.
Ah,
And
yes.
the sort of idea that if someone's exhibiting PTSD symptoms, then something must have happened to them, whether they can remember it or not. And if they can't remember it, the response itself is evidence of the trauma exposure, and we just have to keep digging until we find it. And that actually, through that process, you can falsely introduce the idea of a memory. You can convince someone that something has happened to them.
Huh. That is fascinating. I remember how important that was with the Shanley trials. I think that was when these kids were grown up and they were charging this former priest with sexual abuse. And they got all these specialists, including psychiatrists, to testify that suppressed memory is not a thing, that
Mm-hmm.
it's false memory, that it was made up because suppressed memory doesn't exist. And then later on, they completely threw that out and said, okay, no, there's a lot of evidence for suppressed memory.
Right.
So, so yeah, and it's interesting that we denied that for so long.
Yeah, it's such a complicated relationship. One of the points that I've heard from forensic psychiatrists, I'm not forensic trained, just full disclosure, but the idea is that memories that people have are not static. It's not like you take a picture and store it on your brain hard drive. It's dynamic. So every time you access a memory, you bring it forward and it becomes malleable again. So the idea that there's this sort of true core memory somewhere, it's not necessarily true. And every time you recall an event, it can be subject to change. Even the details of the event, you can change by questioning. And then when you store the memory again, those new facts that you've discussed become part of that memory. So I was always told if someone is in the emergency room and potentially suffered a sexual assault and it's a child, because we worked in the child ER, don't ask too much about it for multiple reasons. You don't want to re-expose them to the trauma,
Yeah.
but also let the forensic investigators do the initial evaluation because they're specially trained in how to take a history without changing anything, without altering that recollection. Because we know that denial and repression and all of those are psychological defense mechanisms. And certainly people have experiences that then they can't remember on purpose. Their brain is protecting them from it. In PTSD, sometimes, especially if the trauma was pre-verbal and stored in a different part of the brain, you may never know. You may never be able to get there.
Mm-hmm.
And honestly, sometimes that's okay as long as the person gets better and does better. And there are different types of trauma treatment, like prolonged exposure treatment, where you do have to access that memory. And the whole point is to change the narrative around it and alter the experience. But sometimes there are certain types of trauma treatment where it's really not that necessary to access the specific memory and event as deeply as possible. So much it is to focus on how to minimize how your response to that experience is interfering with your life, something like CBT, cognitive processing therapy.
Exactly. And especially young children, if they were exposed to that trauma when they were very, very young, like you said, pre-verbal, there's just no registering of that memory as a verbal concept. And so you remember it in your body, maybe you remember it in your sensations, and emotionally, you remember fear. If you smell something, you suddenly have fear. But it's not a problem for a long time. It's not a problem until it's a problem. And so
Mm-hmm.
then you run into maybe major stressors in your life, maybe depression, anxiety, panic attacks, whatever it is. And then you have to kind of dig deeper. But it does make me think about how, insurance companies do not consider PTSD as a serious mental illness, SMI, for which you can be hospitalized for, because it's not the PTSD, it's the subsequent culmination of symptoms like major depression or bipolar schizophrenia. Sometimes that can be related to a traumatic event. And so those are things that we bill for and people get hospitalized for. But the PTSD itself, even though I think it can be a core etiology, is not recognized in that way, which is quite upsetting in some ways, but yeah.
No, absolutely true. I think it's really important. And it's even to the extent I think that there's a debate, a discussion about our fundamental diagnoses that we have in the DSM just straight up wrong because we haven't seen them through a trauma lens. So there is another diagnosis that we haven't talked about, complex PTSD, cPTSD, that is not an officially recognized diagnosis in the DSM or the ICD-10. It is officially recognized in the ICD-11, and it's based off of the idea that someone experiences a trauma that is so profound that it fundamentally changes how you view and relate to the world, that it's more than isolated hyperarousal or re-experiencing or nightmares. It's more than just a collection of symptoms. It's a change in your relationship to everyone and everything in your life. And how you relate to everything and everyone in your life is your personality. So there's an active area of debate, and some people think they're still separate diagnoses, but borderline personality disorder and complex PTSD, if you read the symptom list, are very similar. One focuses more on the personality characteristics and dynamics and symptoms, and the other focuses on more the experience that might have caused this in the first place, that this evolved from that traumatic exposure. And in treating the trauma itself, you can ameliorate the symptoms, whereas treatment for BPD is typically focused more on functional skills and improving the symptoms themselves. So even one of our oldest diagnoses, one of our most established diagnoses, is being thrown into different lights by focusing on the trauma itself. So I think a greater understanding of PTSD and a greater recognition of how trauma impacts people from our field in general is really important. I'm glad that we're taking the time to talk about this.
Yeah, absolutely. Okay, so we talked about that it has to be actual or threatened death, serious injury, or sexual violence. This can be direct or witnessing in person, or learning that it occurred to a close family member or friend. And also, it pertains to if this is part of your profession. So, if you're a first responder or a police officer and you're having to witness over and over these gruesome crime scenes, that can certainly be a risk for PTSD. SAMHSA defines individual trauma as an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has long-lasting adverse effects on the individual's functioning and mental, physical, social, emotional, and spiritual well-being. Go SAMHSA. It's great.
Go SAMHSA.
Very
Totally agree.
thorough.
Yep.
Spiritual in there, yep. This concept includes the three E's: the events, the individual's experience of the events, and the effect. Great. Yeah, I think that really sums it up pretty well. Sometimes
Yeah.
the DSM language is hard to understand, but SAMHSA does a great job just kind of making it more easily understandable.
I think so too.
Yeah.
And it's interesting because as you were saying that, I sort of realized something that I hadn't thought of until this moment, that we spoke earlier about the stigma against Shellshock and the stigma against PTSD, and that people who experience that, they weren't trained hard enough or they weren't strong enough, and how, now we recognize how silly that is. But I didn't realize that I sometimes feel the same way in our own field, or sort of recognize that. So, as you're saying, some people, as part of their job, witness or learn about repeated trauma, especially to children, like police officers, or therapists and psychiatrists. We worked in the ER all the time, right? And we have different language. We talk about burnout, we talk about empathy fatigue, but really there is the recognized phenomenon of secondary trauma, where going through repeated trauma interviews can have an impact on someone to the extent that you can actually develop PTSD because of that. And even then we have all this literature about physician wellness and sort of processing groups. And maybe if you are more sensitive, you limit the number of PTSD cases that you see in a day. So really, I'm carrying around the very same things that we were just talking about. It's interesting that sometimes the mirror flips around on yourself, isn't it?
Yes, absolutely. I feel called out, Dr. Kelly. Yes, it's so true. I remember graduating and thinking, I'm going to see half kids because this is too hard to
Hmm.
just constantly think about how much these kids are suffering. Not that it's any easier for adults, but I think with kids, there's a different level of helplessness, because they just don't have a lot of that autonomy. So, yeah, absolutely. And we talk about debriefing or we talk about supervision, and that's really helpful. But at the end of the day, yeah, there are some days that I'm just needing to zone out for
Hmm.
hours because it's just I can't take anything else into my head. So you're totally right, probably. We need to add therapist psychiatrists in this definition one day.
Yep. Yeah. So you and I have a job that
Yeah.
will we're going to change the field and recognize this more thoroughly.
Yes, exactly. Right. Starting with this little podcast here.
Yes,
Yeah.
exactly.
Yeah.
No, it is, I'm making light of it, and that is also one of my defense mechanisms that I commonly employ, but I think that it is something that we need to both take more seriously as a field and also give ourselves a little grace about that, if you've had a hard day because you've been swimming in trauma after trauma after trauma with patients, that has an impact. That's I say it all the time. You build up your calluses, you build up your armor around that, but at the same time, there's a I don't want to say cost. That's maybe not exactly the right way to think about it, but there's an impact to doing that day after day repeatedly. So, give yourself a break. Take a day off every once in a
Yeah.
while.
Right. Yeah, exactly. Yeah. And speaking of, prevalence and impact here, it is quite common. It's around 2 in 3 people experience a traumatic event in their lifetime, especially like accidents and assaults. So, yeah, who doesn't experience something traumatic? And despite this, most survivors of trauma do not develop PTSD. 1 in 14 people, which is about 7%, will meet the criteria for PTSD in their lifetime. In the US and Canada, lifetime prevalence ranges from 6.1% to 9.2%, and the annual prevalence is approximately 3.5% to 4.7%. So small, but not totally unusual. Full criteria for PTSD is sometimes difficult because you have people who are very much avoidant, and so you don't experience some of the intrusive symptoms because there's just no trigger. They absolutely avoid it at all costs. They may experience brief symptoms or anniversary reactions, but generally function well. Yeah, anniversary reactions are such a huge thing. I always ask, how long has it been? It's a
Hmm.
year mark. That's a really important thing to recognize, especially with the way that our bodies register seasons and the change and the temperature. I think it has something to do with the sensory activation at the time of the trauma. Yeah.
I just
Yeah.
I have to say it because people who are listening to this are going to be screaming, "The body keeps the score. The body keeps the score." So there is a book that talks very explicitly about the physiological response to trauma and how that becomes physical in a way. And so we do have to keep that in mind, that sometimes the traumatic response, the hyperarousal, the hypervigilance, the memories, they're cognitive and people remember them and have nightmares and consciously recognize them. And sometimes you walk into a room and for no reason you can identify, you have a panic attack. But if you look back, it's because it looked like the room where something terrible happened in the past. And so I think your body is a good instrument to letting you know what's going on in your environment. And sometimes those instincts are really important. And sometimes more physical treatment or physical activation treatment for trauma can be really important.
Yeah. Oh, that book changed everything for me. Yeah. But unaddressed trauma can significantly increase the risk of mental health and substance use disorders as well. And also chronic physical diseases like lupus, rheumatoid arthritis. These inflammatory conditions are shown over and over again to be linked to trauma. So, interestingly, this is relevant when, as a country, we have to find ways to defend ourselves. And so the Department of Defense has spent over $2.7 billion on PTSD research between in combat veterans between 2007 and 2010. This is wild to me. It shows us, first of all, that it's very much recognized. It's very, very important. But sadly, Nowadays, that research fund has dwindled quite a bit, but at the time it was very robust and abundant time for PTSD research. Also, out of that, one of the best and only free anonymous self-directed information provided by the government came out. We'll put it in the show notes, but it's ptsd.va.gov.
Yeah, it's one of my favorite resources. So one of the big pushes from the researchers in the Veterans Administration was to get through stigma and trauma and to increase access as much as possible. So there's a lot of self-stigma and stigma against others in the military. And so the idea of going to see a therapist or going to see a psychiatrist may have been a bridge too far. Might have been a little bit too much to commit to, even to address some of these symptoms, even for those who are suffering the most. So they created a bunch, actually, in different domains of totally free, completely online, can do it in your home, totally anonymous. You don't need to create a login, self-directed treatment courses. There's one for PTSD, there's one for ACT, there's psychological first aid. There are a number. Obviously, PTSD is what we're talking about, but it's evidence-based, it's free, and they use some military-specific language, things like deployment, but anyone can use it. Kids, adults, and so I recommend it pretty frequently. It's a phenomenal aid to somebody going through dedicated psychotherapy, and it can be an excellent resource to people who are just starting to sort of explore this for themselves.
Yeah. Okay. Maybe we'll
I think we might have to stop.
Yeah.